Good evening. Hello, good evening. Can you hear me?
Hello, yes, we can.
Oh, hi.
Yes, we can.
Hi. Good. This is, my name is Dr. Mouza. I'm Associate Professor of Surgery in the UAE University and in Tawam Hospital. I would like us to talk about recent updates in breast cancer. And this webinar is hosted by Hamdan bin Rashid Al Maktoum Award. للشيخ حمدان بن راشد المكتوم Foundation is for Medical and Educational Sciences. And he, God bless his soul, had a vision in medical sciences. And this association is pioneer in medical research to empower exceptional students and research in the medical field. And I would like us, can we have the other, please, slide? I'd like us to remember, please, that we have some questions at the end of the session as a panel discussion, but everybody can write their questions on the question and answers box, and we will try to answer them. There will be certification at the end of the session, but before that, we'll have to answer some poll. Recording will be available and can be asked from the Hamdan bin Rashid Medical Association and Foundation. Should we start with the first talk? The first talk will be recent advances in triple-negative breast cancer, and it's Professor Melinda Telli. Professor Melinda Telli is Professor of Medicine in the Division of Medical Oncology at Stanford University School of Medicine. She's the Director of Breast Cancer Program at Stanford Cancer Institute and Associate Director of Stanford Women Cancer Center. Dr. Telli research focuses on development of novel therapies in the treatment of triple-negative breast cancer and hereditary breast cancer. She is a member of the Journal of Clinical Oncology Editorial Board and a fellow of the American Society of Clinical Oncology. She co-chairs a lot of associations. I would like to welcome Professor Telli and recent advances in triple-negative breast cancer.
Thank you very much. I'm going to
Thank
share my slides. Okay. Well, it is a great pleasure to be here with you this evening. For this webinar for me, it is early in the morning. The sun is just coming up in California. I'd like to talk today about recent advances in triple-negative breast cancer. So I thought I would start today and talk about a patient that I first met 17 years ago. She was 33 years old and was diagnosed with a locally advanced triple-negative breast cancer shortly after pregnancy. She was found to have a BRCA1 mutation at this time. She started chemotherapy with our standard at that time, which was AC chemotherapy followed by a taxane, and unfortunately had minimal response to that treatment. She went to surgery and was found to have extensive residual disease. She was worried, and certainly we were worried as well. Based on some emerging data at that time, she did go on to receive additional platinum-based chemotherapy after surgery. And fortunately, she is alive and well today, turned 50 this year. And you know, I think if we think about a case like hers, and compare where we were then to where we are today, our standard of care has really changed. Patients like her that would be diagnosed today, we would routinely incorporate platinum chemotherapy, checkpoint inhibitor immunotherapy with pembrolizumab, and we also have a PARP inhibitor, adjuvant olaparib, that a patient like her would be eligible for. So I think it really highlights the changes that we've made. So this is where we were back then. Our adjuvant treatments for triple-negative breast cancer consisted of anthracycline and taxane-based combinations. Certainly, we had other cytotoxic chemotherapy drugs, but their selective use and targeting by subtype really wasn't optimized. We had no approved targeted therapies and really no clear treatment standard in the metastatic disease setting, with survival being quite short after a relapse on the range of 12 to 18 months. Habibi improves both disease-free and overall survival. That pembrolizumab added to neoadjuvant chemotherapy improves event-free and overall survival. That the PARP inhibitor olaparib in the adjuvant setting also improves overall survival for patients with germline BRCA1 and 2 mutations. And finally, that carboplatin, when we add it to neoadjuvant chemotherapy, anthracycline and taxane-based, it also improves survival. If we look in the advanced disease setting, there have been a number of notable accomplishments there as well. We saw the PARP inhibitors, olaparib and talazoparib, approved based on progression-free survival benefit for those patients with germline BRCA1 or 2 mutations. Pembrolizumab got approved as an initial treatment in combination with chemotherapy for PD-L1 positive metastatic triple-negative breast cancer. And then finally, we saw the antibody drug conjugates, sacituzumab govitecan, as well as trastuzumab deruxtecan, improving survival for patients with advanced disease. So I want to walk through how we got there. And certainly, I think a good place to start is, with this paper published more than 20 years ago now, reporting on the intrinsic subtypes of breast cancer by gene expression. And in this paper, there was a subtype of breast cancer that was defined by gene expression, referred to as this basal-like subtype. These were tumors that tended to be ER negative and HER2 negative, and had a very distinct gene expression profile that really resembled that of the basal epithelial cells in the normal breast. It was around 2005 that this use of the term triple-negative breast cancer entered into our medical lexicon to describe these cancers that were estrogen receptor negative, progesterone receptor negative, and HER2 negative. And early on, there were a number of studies that really tried to characterize the clinical features of this subtype of breast cancer and its epidemiology. We learned that triple-negative breast cancers have a higher risk of early recurrence compared to non-triple-negative tumors. When they recur, there's a much higher risk of visceral or organ-based metastatic spread. And we also learned that these tumors tend to be overrepresented in younger women and in women of African ancestry. Another early observation that really ultimately proved important therapeutically was an association identified between triple-negative breast cancer, this basal-like subtype by gene expression, and BRCA1. So it was found that for patients who develop breast cancer and if they carried a BRCA1 mutation, about 75 to 80% of the time, these tumors were triple-negative and basal-like. And this was important because a few years later, in 2005, there were a couple of really important papers that were published showing that BRCA1 and 2 deficient cells are markedly sensitive to the inhibition of an enzyme called PARP. And the idea was that if you block PARP, that will disturb single-strand DNA break repair. And in the setting of a BRCA1 mutation or BRCA2 mutation, where double-strand DNA break repair is deficient, this leads to a synthetic lethal interaction, profound cytotoxicity. And really, this is the data that launched the clinical development of PARP inhibitors for patients with breast and ovarian cancer. And so a few years later, 2009, 2010, this is when we began to see early reports showing proof of concept that PARP inhibitors did have single agent activity in patients with advanced cancers with a BRCA1 or 2 mutation. We also saw data that the DNA damaging chemotherapy drug cisplatin was also particularly active in patients with BRCA1 associated cancers. And, there was a lot of interest in this space at the time, and a hypothesis that potentially, if we look beyond those patients with germline BRCA1 and 2 mutations, given this association with triple negative breast cancer, would there be some of these DNA repair defects more broadly found in patients with sporadic triple negative breast cancer? And there was a lot of work done looking at various types of biomarkers, really to try to capture this biology, HRD biomarkers. This was an area of really significant research. And this hypothesis was tested in the TNT trial, which was a really important one from England. It looked at randomizing patients to a platinum chemotherapy as an initial treatment, carboplatin, or to docetaxel, a taxane, in the first-line treatment of either triple negative or BRCA mutation-associated metastatic breast cancer. And so this study showed that compared to the taxane, carboplatin in the all-comer population performed very similarly. But if we look at those patients who had BRCA mutations, these patients had a much higher rate of response with carboplatin compared to the taxane. And this was true for those patients who had inherited or germline mutations, as well as those with somatic tumor mutations. Unfortunately, in the study, the HRD biomarkers could not identify a separate group of patients that would be more likely to benefit from platinum. But nonetheless, moving forward some years, it was 2018 when we saw the pivotal trials of PARP inhibitors for patients with metastatic breast cancer associated with a germline BRCA1 or 2 mutation. This was the Olympiad trial with olaparib and the Embraca study with talazoparib. And both of these showed improvement in progression-free survival compared to standard chemotherapy, leading to regulatory approvals initially in that year. And with benefit observed in the advanced disease setting, we then went on to look at PARP inhibitors in the early stage high-risk curative setting. And this was the Olympia study, which was really an amazing worldwide effort to enroll patients with high-risk early-stage breast cancer and a BRCA1 or 2 mutation. Over 1,800 patients were enrolled to this trial and were randomized to receive olaparib for 1 year orally or placebo after the completion of their curative intent treatment. We first saw some of the initial data in 2021 showing an improvement in disease-free and distant disease-free survival in those patients who received adjuvant olaparib. And it was in 2022 that we saw an improvement in overall survival. We found that olaparib, not only does it reduce breast cancer recurrence, it reduces the risk of contralateral new breast cancer, but also other secondary non-breast tumors, suggesting that there is a potential benefit in terms of prevention. But in parallel to all this, there were a number of studies, phase 2 and phase 3 trials that were exploring whether we could add on carboplatin to our standard chemotherapy backbone for patients with unselected triple-negative breast cancer. And overall, most of these studies showed that there was an improvement in the rate of pathologic complete response with carboplatin. But really, none of these studies were powered to look at some of the longer-term survival outcomes, and there was a little bit of discrepancy in what was seen in these smaller studies. But a couple of years ago, at the San Antonio Breast Cancer Meeting in 2022, we saw this important trial from India, from the Tata Memorial Center, a phase 3 trial looking at the addition of carboplatin to standard chemotherapy, showing in the neoadjuvant setting an improvement in event-free as well as overall survival. This was a benefit noted to be particularly seen in patients who were younger than age 50, which was interesting. And then at the American Society of Clinical Oncology meeting this year, we saw a very similar phase 3 trial of coming out of Korea that showed the same thing, looking at adding a carboplatin to anthracycline and taxane-based treatment with an improvement in event-free survival and a strong trend for overall survival. But carboplatin wasn't the only chemotherapy drug who's found a new use for patients with triple-negative breast cancer. This was an important study, CREATE-X, that came out of South Korea and Japan, looking at adjuvant capecitabine for patients with high-risk HER2-negative breast cancer with residual disease after standard neoadjuvant chemotherapy. And I'm showing here the results for the group of patients with triple-negative disease, very clearly showing an improvement in both disease-free and overall survival with 6 months of adjuvant capecitabine. The next big area that I want to turn to is immunotherapy, and certainly the last 10 to 15 years, it's been a really exciting time across all of oncology as we've seen the introduction of checkpoint inhibitors that target PD-1 and PD-L1. Early on in breast cancer, there was certainly a lot of concern that breast tumors weren't particularly immunogenic. But advanced strategies were advanced that really tried to combine chemotherapy with these immune checkpoint inhibitors to try to inflame the tumor microenvironment with the chemotherapy and thereby enable the checkpoint inhibitor to work. And so this was around 2013, 2014 that we started to see these papers coming out showing the importance of tumor-infiltrating lymphocytes in triple-negative breast cancer, that they're more frequent in triple-negative tumors compared to other tumors, and that the more of these tumor-infiltrating lymphocytes you have, the better the prognosis. There was also reports showing an increase in PD-L1 expression in triple-negative cancers compared to non-triple-negative cancers. And so Keynote 355 was one of several phase 3 trials that really evaluated this idea of adding a PD-1 checkpoint inhibitor to chemotherapy in the first-line treatment of metastatic triple-negative breast cancer. What we ultimately found from this trial was that there was an improvement in progression-free survival and also overall survival with the addition of pembrolizumab. But it wasn't seen in all patients. It was seen in only those patients, about 40% of the overall population, where the tumor was PD-L1 positive with a CPS score of 10 or higher. This did lead to the initial regulatory approvals, though, full approvals in the summer of 2021. And when pembrolizumab received regulatory approval in the advanced disease setting in that same year, it also received the first indication in the early stage treatment of triple-negative breast cancer. So this is a really important study, Keynote 522, that basically took patients with stage 2 or 3 breast cancer previously untreated, and they received chemotherapy, which was platinum containing, and were randomized to receive pembrolizumab or not. It was given concurrent with the chemotherapy prior to surgery, and then continued for 9 additional cycles following surgery. The first data we saw was that there was some improvement in the complete response rates at surgery when pembrolizumab was added. But it was really this data showing very clearly an improvement in long-term outcome, event-free survival. The plot in the middle is showing the event-free survival at more than 5 years of median follow-up, with about a 9% absolute difference in event-free survival when we add pembrolizumab to chemotherapy. And just very recently, last month, at the European Society of Medical Oncology meeting, overall survival was reported from Keynote 522, showing about a 5% improvement that was statistically significant for patients who received pembrolizumab with chemotherapy. So this was really great to see, and I think we do feel this in our practice, that patients today who are receiving pembrolizumab, fewer patients are relapsing. The last big area that I want to turn to is to the antibody-drug conjugates. This has been a really exciting space. And the first antibody-drug conjugate that came into the treatment setting for triple-negative breast cancer is this drug, sacituzumab govitecan. It's an antibody against an epithelial antigen called TROP2, and it's linked to a chemotherapy payload SN38, which is a topoisomerase 1 inhibitor. And this was the phase 3 trial, ASCENT. It took patients with more heavily pretreated metastatic triple-negative breast cancer and randomized them to sacituzumab govitecan or standard chemotherapy. And we saw in this ASCENT trial an improvement in progression-free survival, overall survival, as well as increased response rates, again, leading to regulatory approvals for this compound. And then most recently, we've seen this drug enter into the treatment landscape as well, trastuzumab deruxtecan. It was initially approved for HER2-positive metastatic breast cancer. It is an antibody targeting HER2, and it's linked to DXd or deruxtecan, which is also a topoisomerase 1 inhibitor payload. And this was really an interesting approach to try to look at this agent for tumors that weren't classically HER2 positive, but that nonetheless had some HER2 expression and were therefore considered to be HER2 low. And so this was the DESTINY-Breast04 clinical trial that randomized these patients with HER2 low breast cancer to trastuzumab deruxtecan or standard chemotherapy. And there were only about 60 patients that were hormone receptor negative and HER2 low, so essentially triple negative HER2 low. But what I'm showing here is the data in that group And it really was in line with the larger population, improvement in progression-free, as well as overall survival and substantially higher objective response rate. And so when this achieved regulatory approval, it was approved for HER2-low breast cancer, which included triple-negative breast cancer. And so I just want to conclude. I hope that I have shown you that there has been real progress made in triple-negative breast cancer. If we look at the new drug approvals, all of these have come in the last 6 years, and I do believe that in the next 5 to 10 years, many more will come. There were many, many more important questions and hypotheses that were tested that I didn't cover in this talk. These were hypotheses that didn't advance, but I think certainly there were very valuable lessons that we learned from these investigations. I think this is triple-negative breast cancer. It's a wonderful example of how the field can advance when focused. And I'm really struck by the fact that contributions came from all over the world, and it really highlights the importance of collaboration in science. So thank you.
Thank you, Professor Telli. I think we will keep the questions till the end, if your time allows. And I would like to introduce Dr. Abeer Alsayegh. Dr. Abeer Alsayegh is a medical geneticist with strong background in genetic disorders and familial cancer syndromes. Dr. Abeer had her medical genetic training in the University of Calgary, Canada, and she's the head of the cancer genetics clinic in Sultan Qaboos University Hospital. She is also a researcher in a lot of cancer genetics and other genetic disorders. What we would like to do and talk about today is genetic of breast cancer, an update from Oman. Dr. Abeer, please.
Thank you very much, Dr. Mouza, for the kind invitation. And it's a great pleasure to be with you today. I'm a clinical geneticist, I must confess, by profession, and I'll be sharing with you the updates on the genetic susceptibility of breast cancer. I also thank Professor Telli for the very comprehensive information that she gave. She will definitely make my presentation much, much easier now. The outline of this talk is to show everyone in the field how do we do the risk stratification from a clinical geneticist point of view, an overview of what is already known in the field on the genetic susceptibility, how to test for this susceptibility, and some future directions. Of course, I mean, I'll just throw this in. I don't need to say this for this particular audience, that breast cancer is a major cause of morbidity and mortality in GCC and, of course, throughout the globe. In GCC in particular, it is #1 cause of morbidity and mortality, and it's the most common cancer in female. Now, luckily, I mean, you clearly saw that even in clear triple-negative cases, improving diagnostic technologies and the new treatments that have come into the field have dramatically improved the outcome of patients diagnosed with breast cancer. So we geneticists, we like to look at risk factors grouped into 2 types of factors. So there are group factors that you have no control on, and there are risk factors that you have a major hand in trying to control them to prevent your risk or reduce your risk of breast cancer. So I'll start by talking about things that you can do to reduce your risk. So exercise, for example, has shown to actually be very powerful in reducing your risk, even in cases where they have been diagnosed with cancer. Maintaining a healthy weight is also considered a major risk factor reduction. And of course, having a very balanced lifestyle, balanced alcohol intake, and of course, very active lifestyle. Now, things that you cannot control, of course, I mean, they're mainly related to your gender. You cannot choose. Females at a higher increased risk of developing breast cancer. Things like age. The more you age, the more your risk increases. You have no control on genetic factors. There's something that we actually inherit from our parents, and this is something that you cannot actually really change or interfere with. Early menopause, family history, late menopause, and there are other things that are actually known that you cannot control. Now, as a geneticist, I must emphasize here that the most powerful tool, of course, technology has helped us a lot to identify the genetic predisposition to many different kinds of an identification of the genes and in high-risk families. But most importantly, I would like to emphasize today that there is really nothing more powerful than taking a very detailed 3-generation family pedigree. And we geneticists, we like to be very detailed. We take information not only on those who are affected with breast cancer, but we are also interested in knowing how many family members are there in addition to affected that do not have the family history of breast cancer. Always, and of course, when we talk about family pedigrees and taking family history, we don't only focus on one type of cancer. So I would always encourage, so everyone, when you take a family history, to include all kinds of cancers in addition to breast cancer. Ages of diagnosis become very important, ages of death. The kind of treatment that received sometimes may be helpful in patients where you have no medical records. Especially in some countries, patients would come in and give you, family history and say, well, my mom and dad had an abdominal tumor. And in this case, the more information you get medically and the more information you can get from the different documents that the patient may have, the more information you have, the more you can decide on really what is the syndrome that the patient has or what is the most likely genetic etiology in that patient. As a geneticist, we have been having this pie chart ever since I was a trainee. So we divide them into 3 different groups. Of course, the majority of patients, up to about 80% of the patients, they're usually sporadic, so you don't have family history. And in the majority of cases, actually, we start telling the patients that actually breast cancer is caused by multifactorial factors. And at the end of the day, we counsel the patient and tell them, in the majority of cases, even in those who were diagnosed at a young age, it's usually multifactorial, where there are different factors that come into play that contribute to the susceptibility and predisposition to the breast cancer. Only in a minority group, which is estimated to be 5 to 10%, in the maximum, it will reach to 15%, where a risk factor, an inherited risk factor, is identified. And of course, in the group in between, which is the familial type of patients, where there is usually, we hypothesize a mix of genetic plus non-genetic and shared environmental factors that may be involved in the etiology of cancers. I like to use this graph, which shows that, again, because I don't want people to get worried and think, because we all talk about genetics all the time. In the majority of cases, actually, we do not identify a high risk or a Mendelian cause for cancer. And the opposite is true. Only about 10 to 15% of patients are known to have or to carry a mutation that is passed on from one generation to the other. In the majority of the inherited types, it's usually a BRCA1 or a BRCA2 mutations. So BRCA1 and BRCA2, they compose about 60% of the patients with familial breast cancers. And about 40% is really the other different risk factors. And initially, people used to think that there might be a third BRCA gene and autosomal recessive gene. But literature now is showing us that actually there are more the moderate risk and lower risk alleles that may actually have a genetic predisposition, but it's not high as the BRCA1 and BRCA. So basically, on their own, the moderate risk and the low risk alleles cannot be blamed for the genetic predisposition. This is a very nice slide, actually, that shows the timeline of the search for the genetic etiology in early onset breast cancer. There has been really many, literature and papers that talked about finding patients with familial predisposition. But the breakthrough was actually in 1994, where BRCA1, BRCA1 gene has been identified in February of that year, followed by BRCA2 in September of 1994. In 2003, that was when, all the hard work in genetics paid off. That's when actually the human genetic project was finalized and completed. And once that was done, and actually the first human genetic project, it took about 13 years, and they spent billions of dollars to actually decipher the genetic code. And once that happened, then from there was a revolution and major advancement in the way that these genes were sequenced. And currently, we are actually able, within just a few hours, to sequence these genes without a lot of effort and at a much, much lower cost. This actually shows you, this slide, how do we actually group these genes? We group them into high risk, moderate risk, and low risk. The high risk genes are the high penetrance genes, are the ones that increase 10 to 20 times fold the risk in patients. And they are very, very rare to be found. So examples of this would be BRCA1, BRCA2, P10, TP53, STK11, and CDH1. And these genes are actually very difficult to be found in the general population, followed by the moderate risk alleles, where they are not as rare, but still not very commonly found, and they would increase the risk, but not as the high penetrance genes. And for this reason, we call them the moderate risk genes. So they increase the risk by about 5 to 10% compared to the general population. And of course, at the right side of the slide, the common low-risk alleles that have been identified by GWAS studies, and these are commonly available, especially throughout the population. And these are the most difficult ones that you cannot really quantify what it means for the patient if you find one of these genes. I really thank the previous speaker, Professor Telli. I'm showing you this slide to show you that there is really difference between doing the tissue testing. And of course, I think the majority of the clinical oncologists in the audience, they're very familiar with this slide. And this slide actually classifies the different kinds of the types that you can see according to the gene expression profile. So usually the information we get from this test and this information is to choose the right therapy for the patient, and also to give you information about the prognosis on these patients. Whereas when we talk about germline testing, we actually, give different kind of information. So this would usually provide you with the chance of this being genetic passed on through generation. And this is usually the information that other families would benefit from. We can do somatic testing on tissue, but always remember that it really does not give you accurate information on your germline or genetic susceptibility in future generation. So I'll be quickly now giving you some information on the genes that are known to increase the risk of breast cancer. And on their own, they can be, causing the genetic etiology. So they're causal on their own to cause breast cancer. So BRCA1 and BRCA2, not only they cause breast, they also cause ovarian, contralateral breast cancer, fallopian and peritoneal cancers, male breast cancers, prostate, pancreatic, and melanoma in certain populations. In some certain ethnic backgrounds, like for example, the Ashkenazi Jewish, these very rare alleles may be found in abundance, and that could be due to the presence of founder mutations in certain ethnic backgrounds. For example, in the Ashkenazi Jewish population, about most of the population carries 3 common genes, 2 in BRCA1 and 1 in BRCA2. So in such populations, actually doing and starting that specific mutation is very cost effective. So instead of going and spending money on a panel, you can actually start by testing for the founder mutation or the specific mutation that is more common in your population. There is, of course, a huge variable penetrance, even in the same family members. And I think we have all come across patients where the daughters who are in their 20s or 30s would be affected, but their mom, who's in her 60s and 70s, would still be not affected with any kinds of cancer. And this just proves how even in patients who have got genetic predisposition, at the end of the day, it's multifactorial. And there are many other factors, be it genetic or non-genetic, that actually change the risk in even the same family members. I just wanted to show you this slide. This is something that actually we show the patients when we see them for counseling in the clinic, to inform them about all the risks associated with their BRCA1 and BRCA2 mutations. Again, I must also emphasize on the point that although we know all of this information, we cannot tell the patient when and if they develop these various types of cancers. We provide them with the numbers, we provide them with the ways that they can reduce the risk by, be it screening or prophylactic surgeries, which I think is going to be also discussed later today in this webinar, but we do not really, interfere with the final decision of the patient. This is just a slide to show you that there is a lot of information in the literature on the specific ethnic groups that have identified founder mutations. And in those groups, actually starting with a familial mutation may be more cost-effective. Another syndrome that is a worst nightmare for a clinical geneticist is Lefer-Mini syndrome. And this is caused by mutations in TP53, which is also a tumor suppressor gene. This is very rare, highly penetrant autosomal dominant syndrome, and the lifetime risk for breast cancer in this syndrome reaches about 50% by the age of 60, with mean age of diagnosis of 35. These carriers also have increased risk of developing malignancies in radiation fields, and therefore we actually caution and warn these patients to be very careful with radiation that they get. Now, the 5 core types of cancer that we see in Lefer-Mini syndrome are usually premenopausal breast cancer, soft tissue sarcomas, osteosarcomas, central nervous system tumors, adrenocortical tumor, which is very, very rare in the general population, and leukemia. Of course, there are other less frequent cancers that can be seen, and they can also have embryonal cancers. And always remember that these patients, unfortunately, can develop 2 or even 3 cancers in the same patient. There are really multiple surveillance regimes that are out there. There is the European and there is the American, and now we are actually in the phase of developing the Middle Eastern. And I would always advise people that, the physicians that care for these patients, is to really choose the best for their group, depending on what kind of surveillance that is available, because there is no point of coming up with a very sophisticated and very comprehensive screening regime or a plan when actually you cannot offer them those screening methodologies. I just wanted to list again, before actually advising your patient, always remember that there are some phenotype-genotype correlations in some cancers. For example, in the GCC, Unfortunately, we do have even homozygous patients with biallelic inheritance of these genes. And in that case, we always go back to the family history to design and customize the right surveillance for those patients. Another example of a high penetrance gene would be P10, hamartoma tumor syndrome. This is a multiple hamartoma syndrome with a higher risk for benign and malignant tumors of the thyroid, breast, kidney, and endometrium. These individuals can also have very specific skin lesions and clinical features. There is a big percentage of patients that can actually have a head circumference above the 97th percentile, and that could actually help you to make a diagnosis. They have these very distinct skin lesions called tracheoleomomas and papillomatous papules, but the tricky bit is that they usually present later in their 20s. So if you see a patient in their teenager life or before that, you may be not seeing all these features that actually come with time as the patient grows. The lifetime risk of developing breast cancer is 85% with an average age of diagnosis between 38 and 46. There is also a congenital phenotype that you can see in patients, even those who carry the same mutations, which is very interesting in this syndrome. You may see a mom who's diagnosed with breast cancer, and then a child with the same mutation that manifests with what we call in our own lingo, Raleigh-Ruvalcaba syndrome, where they present with proximal myopathy, microcephaly. Some may even have autistic spectrum disorder and the predisposition to develop polyposis, lipomas, and freckling of the glans penis. So these are the skin lesions that may be present in patients. And like I mentioned earlier, that it may really be very difficult to get all the features at younger ages. Again, there are a set of recommendations that are now there. We generally use in Oman the NCCN guidelines. And again, I always would like to stress, always look at, with all these high-risk syndromes, always look at the family pedigree. Because some family pedigrees actually give you clues on other cancers and may help you to make the surveillance plan very customized. I just throw all of this in here, saying that in some cancers, we all know that the effectiveness and the cost effectiveness of screening may not be there and may still be done on research basis. For example, when it comes to trying to prevent endometrial cancers in P10, there is really no evidence, and the majority of screening that is done with really in clinical trials or at research basis. Here in Oman, we use the cancer surveillance guidelines that was really released by the European group. And we found it very practical because it looked at the evidence. And like I really mentioned earlier, that there is no point of stressing the patient with a very strict system when your system cannot really cope with it. Now we come to the moderate risk penetrance genes, and there are very few of them that are out there. One is the PALB2, the others are CHEK2 and ATM. And I must confess here and say that when I was a resident in genetics, this information was not there. I do still remember ordering 2 genes and then waiting for that and then requesting different methodologies on those genes. I still even remember that the cost of those genes in those days were really thousands and thousands of American dollars. And it used to be taking 6 to 8 months for the results to be out back to the patient. Versus now, actually, the majority of these genes are put into one cancer panel. And that's the beauty of actually the risk assessment that we do now. It's that it's faster, it's more cost effective. But the only problem is that the clinical actionability of these genes, in some of these genes, especially when it comes to these moderate risk and low risk alleles, becomes complicated. So this particular gene, for example, it's now considered to actually be as bad, as nasty as, for example, BRCA2 and BRCA1. And we see in our population in Oman biallelic mutations. And once you have the biallelic mutations, you have a completely different phenotype, which is Fanconi anemia, which presents with a multisystemic problem with hallmarks of bone marrow suppression and, of course, solid tumors. The spectrum of cancers include the main phenotype is breast, but there are other cancers that can be seen, namely prostate, pancreatic, and ovarian. Thank God that actually the cumulative risk of breast cancer is only about 33 to 58 by the age of 70. So it's bad, but not as bad as for example, BRCA1. And it has very similar characteristics to BRCA1 and 2 in terms of molecular and gene expression characteristics, and also it has very similar characteristics to the sensitivity to the PARP inhibitors that Professor Telli actually alluded in her talk. The population risk for patients, so always remember that this information changes with time. And I'm sure if I'll be giving this talk in the coming year or 5 years from now, these numbers will completely be different. So if you look at this slide, according to the information we have now, that the female breast cancer risk by the age of 50 is estimated between 13 and 21. And really the risk is not that great when you look at the other types of cancers, like the male breast cancer, the pancreatic cancer, and the ovarian cancer. There is surveillance that is usually suggested to these patients, and the surveillance is very similar to those carrying BRCA1 and BRCA2. If you want to read more, this is a very good paper actually that is produced by the European group led by Dr. Mark Tuskiewicz. And this is a very good paper that actually talks about the best management in patients who are carrying germline mutations of B2. Another gene who also increases 2 to 3 folds the risk. And always remember, this is a gene that is really responsible for DNA damage repair response. Many different variants have been reported, but always remember that really the population that has been studied are mainly Caucasian.
Dr. Abeer,
yes,
if you can
wrap it up.
Yes, please.
Okay.
Thank you.
And of course, I'm getting at the end, I'm very sorry. And of course, the ATM risks, and again, ATM is also one of those that is not considered to be a high-risk gene, and it increases the lifetime risk of breast cancer by 2 folds. There is more to be known. There is really not concrete data and concrete guidelines to actually suggest to patients carrying ATM genes. Now, most of you have heard about direct-to-consumer testing, and these are tests that you could order from a pharmacy or online. I will just say one sentence on this, that they are really not as good as the clinical tests, and they do not really represent very accurate risk assessments, especially in all population. What's next now? People talk, in addition to the panel, the cancer panels, people talk now about the polygenic risk scores, where you have the sum or all variants, moderate risk, low risk, and high risk, and then you can guide the patient according to the scores you get in view of all the risk factors that are out there, be it genetic and non-genetic. The best approach now for cancer germline testing would be a cancer panel. People have suggested using a whole exome sequencing and whole genome sequencing, which I'm sure is going to come in future. But for now, we would advise to stick with the cancer panel and use whole genome and whole exome if you do not find your mutation using the standard method. Whole genome, whole exome can be useful if you are doing a research or if you are into pediatric cancers. Always check the genes in your panel, check the methodology, and choose experienced accredited laboratories. And be very careful when you get gray information. In genetics, unfortunately, it's not white or black. Sometimes you get something called variants of unknown significance, which is beyond the scope of this talk. And you need to always have the experience on how do you counsel for these changes and how do you deal with them. And I'm very sorry if I took more time. By this, I would thank you all for listening, and I'm happy to receive any questions you may have. Thank you very much.
Thank you, Dr. Abeer. I would like to present now my friend, Professor Mehran Habibi, Associate Professor of Surgery in Northwell Health, USA. He is actually the Chief of Breast Program at Staten Island University Hospital and the Director of Breast Surgery over there. He was previously the founding director of Johns Hopkins Breast Center, and we've worked together while Johns Hopkins was actually in Tawam Hospital. Dr. Habibi is an experienced oncoplastic surgeon with massive experience in breast cancer surgery, oncoplastic surgery, and breast mastectomies and risk reduction mastectomies. The talk will be surgical, genomic, and therapeutic advances in breast cancer. Dr. Habibi.
Hello, thank you so much for inviting me. It's great to see you all. Do you see my slide? Can you hear me okay?
Yes, we can.
We can hear you, yes.
Okay, perfect. So my talk is going to be about some updates and what we need to know in 2024. It's my disclosures. So as a background, as other speakers mentioned, with the advancement in imaging, surgical techniques, pharmaceuticals, and devices, the modern breast surgery is indeed very different than what we had around 5 to 10 years ago. But still, unfortunately, as you know, the breast cancer is the most common cancer in women. And in the US alone, this year, we had over 300,000 patients diagnosed with the second most common cause of cancer mortality. But if you look at the big picture over the last 30, 40 years, the mortality of the breast cancer has a nice decline, which is really good. So I'm not going to talk about the genetics. You had a great talk about that. At the bottom line is that at this point in America, any patients with the breast cancer, we do test for the genetic testing. We had in the past some indication based on the family history and all that, but because the price has come down, we just offer the genetic testing with anyone with the diagnosis of breast cancer. The other areas that you're all familiar with, the MRI has a lot of indications now and is essentially moved into the screening space. So when you calculate the lifetime risk assessment with the Tyrer-Cuzick or other metrics, and if it's more than 20%, then they have an indication for doing it in a screening setting, and that increased significantly, and the number of the potential cancers can be detected. If the patient have a breast density, now it's a law in most of the states in America that they need to be notified, and they have to be offered of additional screening tools. One is then screening ultrasound, which is not very practical, but the screening MRI, it's essentially used. In a lot of cases for the breast conserving surgery, we do the test of the MRI to see the extent of the disease as well as if there is a synchronous lesion or not. And a lot of times in the context of the neoadjuvant chemotherapy, because as you know, we do more and more of that, we do the MRI to detect that if there is any lesion. PET-CT, as you know, it's a test that you use now a lot for the cases that they have a node positive disease. We will do the PET if it's a neoadjuvant chemotherapy, and of course, if the patient have metastatic symptoms, we do that. The big kind of like a question that now is becoming more and more in the past several years is that, so we do the surgery first or do the neoadjuvant chemotherapy or systemic therapy first, which in my mind, it depends on several factors. One is the receptor factor is important. The size of the tumor is important, as well as the size of the breast as well as the node situation. So if it's a triple negative breast cancer, or if it's a HER2 positive, if the size is larger than 2 centimeter, or smaller than 2 centimeter, but compared to the size of the breast is large, then we do consider that. If the node is positive, we do consider that as the method to start with the systemic therapy to be able to de-escalate the surgery on the other side. A very quick note on the genomics tests that are available. There are multiple of them, as you're aware. Oncotype DX is a very common test that is used, gives you a 3 essentially measurements of the high, intermediate, and low. The MammoPrint Blueprint, it gives you a big high and low measurements, but in addition, it gives you also that molecular subtyping, the luminal A, luminal B, HER2, or basal subtype, which now is used a lot. The PAM50, the Prosigna, as well as the Foundation Medicine test is used usually in the context of the metastatic setting. But again, now there are variety of other factors. There are Boston gene that is available, that is used, and there are several other genomic tests that in current environment are available. Talking about the surgery, the big 2 operations that we do, as you know, the breast conserving surgery or lumpectomy versus the mastectomy. The new kind of like advancement in the lumpectomy, kind of like a space, is a lot of wire-free technologies. As you know, there are a variety of companies that have the wire-free technology available. I'm going to mention a little bit of that. We talked a little bit about the intra-op specimen assessment and intra-op margin assessment. As you know, the wire localization for the tumors that are not palpable, it has to be done the day of surgery for the most part. Some people do them the day before, but the patient goes home with the wire and is a little bit of a problem. They have to go through the radiology, and they are all NPO, and basically there are some 15-20% that they would have vasovagal symptoms. It causes delays in the OR a lot of times, and you do have to do transporting the patient from the breast imaging to the OR, and potentially can migrate. So at Hopkins some years ago, we did a spaghetti chart, if you would, to look at the movements of the patients when they come in for the localization and from the time that they go for the surgery. These are the movements of the patients or the staff throughout the process in the day of surgery, causing around 2 to 3 hours of the delay. As I mentioned, there are several techniques of doing a wire-free technology. One is an ultrasound-guided resection. It only can be done on the lesions that are a little bit larger and are visible with the ultrasound. But as you know, the ultrasound kind of like a probe is bulky, and a lot of times is larger than the size of the incision when you do for the lumpectomy. It's not very convenient, but it is available. It's doable. The other one that is mostly used to be used a lot, radioactive seeds. These are the seeds that are used for in the context of the prostate cancer, but they can insert them into the lesion itself, and they emit radiation. The problem is that, again, they are emitting radiation that only can be used up to 5 days in advance, and there is a problem with maintaining the chain of custody from the time that you do the resection to the goes back to the nuclear medicine. So if you lose them, it's gonna be a problem. So it's not very convenient. There are other companies one of them is called Savvy Scout that you see here. And there are several of them. And there is a Magseed, there is a Molly, Pintuition, variety of different wire-free technologies. Each of them have pros and cons, but they are really good. So when we implemented the wire-free technology at Hopkins, we're able to really eliminate a lot of those extra movements. The patients would do the localization days in advance, weeks in advance, and then they come in for registration, go to the pre-op holding, and go to the OR with a really minimum delay. So again, the new things about not that new, but about the basic lumpectomy. This is what we got training on when we were residents. You have a mask, you put an incision on top of it, you take it out, and you close. The people will have seroma, and that's pretty much end of it. But what happens is, yes, the seroma, fills up that defect, but then several months, several years later, that seroma gets absorbed and you have a lot of deformity in the breast. Now here comes the oncoplastic kind of like a angle of it. So there isn't, as you know, there isn't a space between the subcutaneous tissue and the parenchymal parenchymal fat is different in every patient. And the best thing to do is to look at the mammogram, the MLO view of the mammogram from the lateral to medial point of view, and it gives you a little bit of the thickness that you see where the gland is, where the skin is, and how much of a space you have. So that gives you the space that you can stay on and safely do the dissection. When you do the mastectomy, you can use it. When you do lumpectomy, you can use it. The thickness varies from 0 millimeter, they are like completely stuck together, to around 2 centimeters or so. Usually we don't get lucky to get that 2 centimeter ones, but half a centimeter, 6 millimeter, it gives you a nice enough fat that you can really dissect without going into the breast. And that's the space I think would be as a breast surgeon, if you get that that space, you're golden. So what we do now, we try to hide the incision into areas that you can. One of my favorite positions is in the areola. Even on the picture you see is at the areola level. To me, it's better to go even 2 millimeters into it. So intra-areolar incision, that's my signature incision, because it's going to blend in and it's not going to be visible. If you do it on the areola, it's more visible than if you do in the areola. So intra-areolar is a great, and you can essentially move around the tissues when you do a lumpectomy. So we make an incision in the areola, in the anterior mammary fascia, the area that I mentioned. You essentially create a flap, and you create a flap much larger, much longer than you need in order to be able to bring the tumor into your wound. You don't essentially extend your wound into the tumor. You bring the tumor into the wound by mobilizing this, all the way. And you don't need to do the tunnel. You just need to shift the entire, plane into you. So once you do that, you see, you bring the tumor into the wound, and you can see it. You can secure it. Some folks secure it with sutures. I secure it with Alice's. And then I just, when you take out, then you go underneath, you mobilize and the tissue in order to be able to bring these 2 columns of tissue together. So you test them to make sure that you don't have much of a pulling on the skin. So you mobilize really more than what you need, but it makes the closure much easier. And then once you do, you can use them underneath as well. And then you close the defects. This is something that we were not trained when we were residents, that you always close the skin and leave the defect open. Not anymore. We will close the defect all the time. It makes the closure much better, makes the post lumpectomy looking much better. So that would be essentially the new easy version of the lumpectomies that I think all the breast surgeons or whoever does the breast surgery ought to really take into consideration. I'm going to talk a little bit about the intra-margin assessment. So the risk of positive margins in the lumpectomy ranges from 0% to 30%. When I say 0%, if you ask any surgeon, they're going to say, oh, our rate is 0%. In my hand, I have no recurrence. I have no positive margin. But when we looked at the data really nationally, it goes up to between 18 to up to 30%. It causes a lot of cost and anxiety for the patient. As a surgeon, we feel that is our failure if you have a positive margin. It can happen, but that's how you feel. Patients are upset. It causes delays in the systemic therapy, which is very important to not have that. There are several companies out there that the 2 that are FDA approved, and I can talk about them. One of them is a Lumicell, which essentially has a component that they have a prodrug that you inject intravenously 2 to 6 hours prior to the surgery itself. So it's a pegylocyanin, which is a medication that has a fluorescein component attached to it together. So it goes to the circulation, goes to the body. Around the tumor cells, there are some proteinases. It's called catepsin and matrix metal proteases. So these enzymes cleave the pegylocyanin and just breaks it. Once it breaks it, it becomes fluorescein. So once you have the fluorescein, you have a probe that you can put into the cavity, and you can detect if you have a positive margins, and then you can take it more. So that's, in theory, it sounds really good. In practice, there are a couple of problems with it. There's a 1% risk of severe anaphylaxis reaction to the injection. You have to inject them 2 to 6 hours prior. Is a little bit logistical problem. And again, the papers that they have did not really show that how much of a decrease in the take back to the OR they will have. But it just recently got FDA approval, and I think is out there, and you're gonna hear more about it as the time goes. The second one that has been in the market, much longer. Again, if you remember, as one of my disclosure, I did some studies, for this company. So it's called margin probe. So there is a probe that uses the electromagnetic signal. It sends the signal to the cells and receives the signal back. And depending on if the signal is basically coming from the cancer or normal cells, it gives you a negative or positive. So the entire thing takes around 2 minutes or so to run throughout the entire thing. And again, is it 100% accurate? No, it's not. But there are multiple studies. One of them were ours, but there are 10, 15 studies that shows that it will decrease the positive margin and take back to the OR by around 50%. So a small mention about the mastectomy. The principles of mastectomy pretty much are the same. Remembering the plane that is very, very important, the oncoplastic plane. If you know that plane, you can do the nipple sparing mastectomy, no problem. Of course, the deep flap and prepectoral flaps implants are the 2-3 new ones. So let me quickly shift to the auxiliary management and the pitfalls. The new medications that are a little bit different than the nuclear medicine. The two of them are the Lymphoseek, which is a mannose moiety, and uses the same kind of like a nuclear medicine characteristics. But the benefits of it is that it has no pain, and it goes to the node very quickly, like around 10 minutes or so. The other one is a MagTrace. So MagTrace is a magnetic component that has no nuclear medicine capability at all. So there's a nice thing about it, is that you can be injected in a lot of centers that they do not have access to the nuclear medicine. The problem with it is that is a magnetic signal, magnetic particles, and it can stays in the breast. If you do the lumpectomy, it shows on the MRI years down the road, but now they know how it looks. So it does not have that much of an interaction, but it is something, and potentially it can go to the other organ, it can do the brain or stuff like that. But it's been approved by the FDA to be used in the context of the sentinel lymph node. Everybody nowadays knows the Z11, Amaros. The SOUND trial is something that they're going to mention a little bit, but the Z11 for the non-surgeons or non-familiar with that study is that, if you recall, there was several years ago, when we did the sentinel lymph node, when the node was positive, we used to do an auxiliary dissection. In this study, they showed that if you have a lumpectomy, is a T1, T2 lumpectomy, and if you have a positive lymph node, you can put it up to 3 nodes. You can potentially forego doing a complete axillary dissection if the patients would get the systemic therapy as well as the radiation. The outcomes were the same. So in the past couple of years, they published the data, 10 years data, and shows they kind of like a fantastic results, and sentinel lymph node alone is the same. So Amaris trial is the Z11 for the mastectomy. At the bottom line is that even in the mastectomy cases, if you do the sentinel node that is positive, you can forego axillary dissection, and the patient get radiation. They have same outcome with less lymphedema. The interesting thing that was published several months ago, was a sound trial. So, but the sound trial, what they did was that they essentially prospectively designed a study for the tumors that are less than 2 centimeters, and clinically, with the ultrasound, the axilla were negative. They randomized the patient between the sentinel lymph node and foregoing the sentinel lymph node altogether. And they looked at the disease, distant disease-free survival, as well as the disease-free survival and all that. As you can see, their local regional relapse was identical. The distance metastases were pretty much the same, and the overall survival were pretty much the same. So with the SAND trial, we moved the needle one more step potentially for a lot of patients with the well-behaving tumors, ER positives, and the small tumors clinically negative. You can potentially forego sentinel lymph node, and that's, I think, is a big deal. So a controversial concept about the sentinel lymph node in the context of the neoadjuvant, chemotherapy. I talked about this, all the time. So the study that is famous, it was several years ago, is a 1071, which they showed that if you do the dual signal, and the validity of the sentinel lymph node is good after the neoadjuvant chemotherapy. So we do this all the time. I actually do even with the single injection. I don't do the blue dye, but if the node is positive prior to the chemotherapy, I always biopsy the clip, and then I find the lymph node out on the other side. And if you do that, if the node is negative, the rate of positive axilla is less than 2%. And I think that is really important to de-escalate from the axillary surgery causing less lymphedema. So I'm not going to talk about the radiation a lot. The new things are the studies that are now currently going on in America. It's called DEBRA trial, in which you can do the oncotype or you can do the mammoprint. If they come back as a low score, if you do the lumpectomy and your nodes are negative, you can forego radiation. This is a prospective study, which I think is going to give us really important answer in going forward. So where are we going to go from here in the next several years? Our robotic already is here. Robotic assisted mastectomies, the cryoablation on I think it's a controversial topic. In the context of the lymph node surgeries, I think nowadays we're doing less and less axillary dissection. Hopefully we would have less and less lymphedema, but I think the lymph procedure and lymph node preventive surgeries I think are important. I mentioned about the localization. So now we can potentially do the localization and doing the wire-free technologies at the time of the biopsy. And I think going forward, using the genomic and genetic information at the time of the core biopsy to design a whole strategy of treating the patients, I think would be something like that. So I'm working on the protocol, I call it GRACE protocol, which essentially using the molecular subtyping to design the study even from the get-go to potentially randomize the patient to different things. Again, these are the upcoming things. And with that, I will stop. And thank you so much for your attention.
Thank you so much, Dr. Habibi. And I think just getting on the time, I can see a lot of questions. The first question, while you're here, someone asked if we can use MRI for...
Dr. Mouza, I think you're muted.
Oh, okay, I'm sorry. I think there is a question asking about using or the role of MRI in assessing resected margins. And I thought I will let you answer this question, because given that we have no time in the OR, I don't think we can use the MRI. Not only the OR time, it's also the feasibility to MRI method and MRI imaging. It is like asking for difficult.
So what I think let me rephrase that question. I think what they are meaning is that having devices in the OR. So there is a like a Hologic has a device called Trident, which is an X-rays of the device in the OR.
Yes.
There are companies that they have a micro CT of the lumpectomy specimen in the OR. There is another company that has a micro
Mozart.
CT. There is a micro. So Mozart is also an X-ray. It's not a micro.
No, it's an X-ray. Yes, it's an X-ray.
So, but there is a micro PET CT. It's called Xeox that is potentially available. I'm very involved in the intra-op margin assessment and all that. I am not aware of any company that has a micro MRI for the. I won't be surprised that they may design it, like that. But as of now, what we have the X-ray, we have the micro CT, and we have a micro PET CT. In addition to the two companies that I mentioned about the intra-op margin assessment. These micro CTs and all that looks at the margin of the lumpectomy, the
extra margins,
the margin in the lumpectomy cavity. So there's a little bit of a difference. I think that area is in active research. I think in coming years we're gonna have better devices going forward.
Exactly. I've used the Mozart, and I think the Mozarts are more feasible for DCIS and microcalcification, especially if you have a lump that has disappeared with the neoadjuvant chemotherapy. You can only see the clip.
Sure.
Yeah, good. Then thank you, Dr. Habibi. I have a couple of other questions. I think I'll start from the beginning. Dr. Telli, there is one question that says, how do hormone receptor status influence treatment options? I thought our talk is about a tumor that is triple negative, and I did not want to interfere. Maybe you can answer that question.
Yeah, sure. So I think, for all breast cancers, checking the three major prognostic markers, the estrogen receptor status, and we've known over time that if the cancer is hormone receptor negative, it will not benefit from hormonal or endocrine therapies. Certainly for those tumors that are hormone receptor positive, there is very clear and substantial benefit for the hormone or endocrine treatments. So for triple negative tumors, these are typically not a benefit.
Yes, I hope we answered that question. Another question, Dr. Telli, when do you choose ADC over PARP inhibitors?
Yeah, I think we have, many riches now in thinking about metastatic breast cancer, lots of different options that would be appropriate in a given setting. I think certainly for me, I think PARP inhibitors can be a nice sort of initial treatment for patients who have metastatic breast cancer with a BRCA1 or 2 mutation. It's an oral therapy. Overall, from a patient's perspective, very nice in terms of generally the side effect profile, no hair loss. There is blood count suppression, sometimes some nausea, but overall it's a well-tolerated treatment. And I think for most patients, if it's an option, certainly they prefer that over IV, more conventional chemotherapy.
Okay, Dr. Abeer, there is one question that says, which is the most common genotype of breast cancer in the Gulf states?
Okay. That's a very interesting question. So according to the literature, published literature, we do seem to have exactly the same, just like the other published populations. So the abundance is, the majority of patients actually carry BRCA1 and BRCA2.
Yes.
In Oman, we do see a founder mutation that is a duplication, a small duplication in BRCA2. But like I mentioned, that despite finding these mutations, we do prefer doing the panel because the panels are very useful in our populations due to increased consanguinity. We actually end up using the moderate risk and low risk alleles to give reproductive advice to our patients. So I can say that our information is just like the published Western BRCA1, BRCA2, and we are starting to see CHEK2, but again, in very limited number of patients.
And Lynch syndrome, Doctor, I've seen a lot of Lynch syndrome.
We have seen some patients who have got, but we still again don't know, because in some of our families, again, because of the consanguinity, we also end up seeing patients with Lynch having also mutations in Lynch. So that's something that we have discovered. This is why I go back to the fact that a panel has really, shown us that when you know that there's a BRCA mutation or population or a Lynch mutation, we still get surprised by getting more than one mutation in
Absolutely.
our consanguineous group. Yes.
Absolutely. I'd like to ask another question, Dr. Abeer. It's from the audience. What is the role of liquid biopsy in screening for hereditary breast cancers?
So this is why I started by saying that to check or to test for genetic predisposition, you have to do the germline testing, because the germline testing is what provides you that kind of info. Now, having said that, I'm sure in future, the technology will be there to identify germline predisposition using other technologies. For example, somatic testing. So somatic testing can give you an idea, but it still cannot replace the germline testing. So the answer is no. If you want to get an accurate, detailed assessment of your genetic predisposition, you have to really get the germline testing by testing a sample of your blood or a sample of saliva. And it's not a tissue testing. Tissue testing, which is the liquid biopsy, is usually used to decide treatment, prognosis, and it has different uses, actually. Thank you.
Well, I think there is another question from the audience, but I did not actually understand the question. It talks about the financial burden of genetic testing.
That's
maybe you
actually a very good question.
Yeah.
Very good question. This is why I ended up my slides by giving you more information on, I mean, we know that even, despite the reduction in the price of next generation sequencing, in some parts of the world, we still lack facilities that would do the analysis. We lack the expertise that looks at the sequences. So I actually would agree, and I personally consider it a major ethical and financial burden. I mean, in our part of the world, we get all these tests funded by public health system, where I'm sure there are places, other parts of the world, where they cannot even afford doing the genetic testing and getting that kind of info. So it is a burden and it is a problem, but with reduction in the technology and the improvement of the technology, I'm hoping that it becomes easier with time. Thank you.
Yes. Well, there is a question from Lema, and I'll answer this question because it's the MENA region. Why is breast cancer incident is noted more in younger age in MENA region rather than the incident age in the West? Is actually not younger age only. I worked 8 years in Germany. It's almost the same incidence in younger and older age. Maybe as Dr. Abeer mentioned, we have some genetic predisposition like the West and the consanguinity. Maybe this is one of the reasons we do see breast cancer in younger age. I think if you see one young patient among 50 older age patients, you get the shock, oh my God, she's young and she was diagnosed with breast cancer. What do you think, Dr. Abeer?
So I agree that we all feel like the burden is increasing. And to be honest, the data actually suggests that we have many patients that are being diagnosed. When it comes to the GCC, I think we have other factors that might have influenced the way that you looked at this, the way that you look at this data, is the majority of our population are actually young. So
yes.
the majority, so we have a bell-shaped graph where the majority of people we see that live in the country are young. They're my generation who have lived after the 1980s that actually are going to be living at an older age. So I think this is the bias of the cases that you see in the clinic. This is one. The other thing is, although you mentioned consanguinity, and we do think that consanguinity may have something to do with it, the answer is we don't have really evidence in the literature
Yes.
that confirms that. And, you know, as a geneticist, I do get, you know, sometimes make these theories that, okay, maybe if we triplicate the number of moderate risk and low risk alleles, that may increase. But to be honest with you, again, there is really not solid evidence that we can rely on to blame consanguinity for the increased risk in breast cancer. The cancer incidence increases when it comes to the biallelic autosomal recessive genetic syndromes. So that's completely different. That's not the autosomal dominant kind that we discussed today. And yes, that we can blame onto the consanguinity bit, like Fanconi anemia, cases of telangiectasia, you know, and you name it, constitutional mismatch repair deficiency syndrome, that is really caused by consanguinity. But I do think that the increase, you know, in the technology, the way you diagnose it, the young population is the reason why we do feel like we have an abundance of young patients diagnosed with breast cancer.
Thank you. Dr. Telli, one more question. I think it's the same question that says about the antibody drug conjugates side effects. How would you deal with these side effects, mainly grade 3 and 4, like diarrhea, neutropenia, and interstitial lung disease? If you could.
Yeah, great question. I think, you know, we first saw the TDM1 introduced many years ago as the first antibody drug conjugate. And I think, you know, we're really impressed with the overall safety and tolerability of that drug. But now we have, for triple negative breast cancer, drugs like trastuzumab deruxtecan, sacituzumab govitecan, and these are very different. These, from a patient perspective, certainly they feel like chemotherapy. I think with sacituzumab govitecan, myelosuppression, diarrhea, these are some of the big issues for patients. Dose reduction can be helpful, adding prophylactic growth factors, and then really trying to be aggressive in managing diarrhea for patients who have that. I think for the TDXD, fatigue and nausea can certainly be limiting for patients. Fatigue can be really profound in a group of patients, as well as the nausea. And so certainly prophylaxing with more, you know, powerful antiemetics is important for TDXD. And then the interstitial lung disease, different studies have shown it's about 10 to 15% of patients will get this. Most of the time it's asymptomatic and just identified on imaging, but it is really important, I think, to know about the toxicity, make sure your patient knows about it, to report any cough, shortness of breath, fever early, and then, of course, to perform chest CT imaging and prompt therapy with steroids if there's concern for certainly any symptomatic pneumonitis or interstitial lung disease.
Okay. The survey will be at the end of the session, where you can fill it and then you'll get your certificate through the webpage. Dr. Habibi, does the periareolar incision increase the risk of tumor recurrence?
No.
Of course. I would love to thank you so much for this, Professor Telli, Dr. Abeer, and Professor Habibi. Thank you so much for attending and giving us this beautiful, concise speaks and lectures about breast cancer. As I said, the survey will be at the end of the lecture, and where you can get your CME certificate. We would like to invite you all to recent updates in anti and postnatal care on the 21st of November, 6 p.m. Dubai time. And the link will be sent to you guys to register. Thank you.
Thank you very much.
Thank you, everyone. Thank you so much.